Jay, good evening.
Yeah.
Good evening, sir.
Dr. Dipan, good evening.
Good evening, sir. Good evening and welcome to this program. And Dr. Jayaprakash, Dr. Bhattacharya, quite a bit of efforts to organize this, which is very good because I think I will start with welcoming Dr. Bram Rochford and Dr. Dipan, who have kindly agreed to spare their time from their busy schedule to talk to our group of experts in anesthesiology and critical care. I must introduce Dr. Bram. Dr. Bram is Associate Professor in Department of Medicine, Division of Critical Care, but he is also in the Department of Health and Research Methods, Evidence and Impact. That is a department which used to be called, excuse me, it used to be called Clinical Epidemiology and Biostatistics, but they have changed the name, which I like, that this name really reflects what they do. He is expert in grade methodology and has many publications and in reputed journals. He is expert in systematic review and meta-analysis. He has published more than 400 papers in top journals with more than 25,000 citations. And the number of citations are increasing every day. So it is always less than what actually it is. He is ICU site in charge and research lead of McMaster University, Hamilton.
Yes, sir. Kameshwar, sir.
Dr. Gordon Guyett, who is, as you know, leader in the field of grade.
Excuse me, sir. Excuse me. Before going to start, I would like to introduce our national president and chief guest, Dr. Bhimeshwar, sir.
Okay. Please go ahead. Please,
Dr. Bhimeshwar, sir, please say a few words.
Yeah, good evening, everyone. Thank you, Bihar and Jharkhand Society of Anaesthesiologists, President Dr. Motilal, Secretary Dr. Ajay, and Jay Prakash, the Scientific Chair, for inviting me to be the chief guest for this wonderful webinar on grade. That is latest. And then we have wonderful speakers, Dr. Bram and Dr. Chaudhary. And Dr. Kameshwar Prasad and Bhattacharya are the moderators for this wonderful initiative by the Bihar and Jharkhand Society of Anaesthesiologists. It's a wonderful initiative, and I wish this webinar all success. Thank you very much.
Thank you, sir. And I would like to also invite Dr. Devetia, sir. Please, sir, say a few words.
Yeah, good evening. And I must commend Bihar Jharkhand Society of Anaesthesiologists for organizing this program. I think one of the ways of assessing evidence and how to incorporate evidence into guidelines is something we all need to sink our teeth in and do it the right way. We are ambitious in making guidelines, and I'm sure this will contribute a lot in the way we make our guidelines and how we assess and evaluate the evidence. McMaster University, Dr. Gayett's group has been helping the ISA in bringing out some of the previous guidelines, and I'm sure seminars, symposia such as these will go a long way in helping our society to do the right things the right way. So I congratulate and thank the Society of Bihar Jharkhand Society of Anaesthesiologists, Jay Prakash, my Dr. Bhattacharya, Dr. Ajay Kumar, and
let me introduce again Dr. Bram Rochford. I have already told you about formal things about him, but I think informally I must tell you that he is one of the pillars of WHO to make these COVID treatment guidelines. Of course, Gordon Guyatt himself has been associated with that. And it was a pleasure to welcome Dr. Bram to RIMS Ranchi for grade workshop, which went on for 2.5 days, practically 3 days, and very successful. People from all over the country came and attended and actually filled up to at least make people aware of the
I feel that the network congestion is there.
Maybe I should just start, Jay?
Yeah,
Yeah, you may proceed.
Dr. Jayaprakash, please proceed.
Yeah, okay,
Okay.
thank you. Yeah, you may start, Bram.
I wanted to start by enormous thanks to the Indian Society of Anesthesiologists for this invitation, to the honorary guests, to Dr. Jay, Dr. Pradeep, Dr. Kameshwar, who I'm fortunate enough now to call colleagues and friends. Very thankful for the invitation to come and give this Zoom webinar on grade. Both Dipayan and I extremely excited about the chance. You can understand it's impossible to address all aspects of grade in a 1-hour seminar, but we'll do our best to provide at least some overview of the crucial aspects. I will start with grade and assessing the certainty of the evidence. Dipayan will follow up from my 25-minute talk, specifically discussing the application of grade to developing guidelines and how we go from the evidence to producing recommendations. But to start, I'll discuss how we apply grade to assessing the certainty of the evidence, and hopefully there will be some time for discussion at the end. You know, when you think about the concept of grade, grade can be used to produce guidelines, and I think that we're all well familiar with the idea of using grade to produce guidelines. Grade can also be applied to assess how certain we are in an evidence base. And that's how I'm going to frame grade, discuss grade in this first 20 minutes, is how we apply the concepts of grade to deciding how sure we are, how certain we are about conclusions that we generate when looking at the summary of evidence addressing a PICO question. And when that comes up, it's usually in the context of a systematic review. And so for those on this call that have participated in a systematic review or meta-analysis before, there's many steps to performing a systematic review. But one of the last steps is looking at the results and deciding how we interpret those results and draw conclusions. And here is where grade can help. An example that I wanted to demonstrate comes from a systematic review that I did and published in Intensive Care Medicine a couple of years ago, looking at the role of high-flow nasal cannula. I think many of us become comfortable with using high flow. I'm sure in the anesthesiology world, you've been using more and more high flow, perhaps for post-extubation respiratory failure, et cetera, in the recovery room. And there's a body of evidence looking at the role of high flow in those with acute hypoxemic respiratory failure. As part of the systematic review, we looked at the outcome of need for intubation, and you can see the pooled effect estimate and 95% confidence interval. The traditional approach, looking at this point estimate and confidence intervals that exclude no effect, would be to say there is a significant reduction in the need for intubation with high-flow nasal cannula. However, when one looks at the forest plot in a little bit more detail, you can see a couple of things. One, there's a number of studies that were at high risk of bias that were included in this evidence summary. Not only that, the upper end of the confidence interval sits right up against the line of no effect. It could not be closer in terms of 0.99. And the number of events, if we look at the total number of events, the studies that were included in this evidence summary were not huge. And the number of intubations also not huge. And so although this was a statistically significant effect that was seen, we decided that this wasn't based on high certainty evidence. In fact, we decided this was based on low certainty evidence, given the issues that I mentioned around precision, low number of events, upper end of the confidence interval that, although did not touch 1, was very close to 1, and issues around risk of bias. And we said that in the abstract. We said this was low certainty evidence around intubation, and we summarized this in the conclusion as the fact that high flow nasal cannula may decrease the need for intubation. GRADE advocates for this idea of migrating away from statistical significance as being the only thing that matters, and instead transitioning to the idea that when we decide about certainty of evidence, there are a number of domains or a number of factors that get incorporated into deciding how much we trust a body of evidence. This idea of moving away from an arbitrary p-value as being the only thing that matters is not new, and one that's discussed a lot in the scientific literature, here from the American Statistical Association, talking about the limitations of p-values and the relatively arbitrariness. Again, from Nature, talking about pervasive issues around the only thing that matters being the p-value. I'm not going to sit here and advocate for a moment that precision does not matter. Precision matters, and width of the confidence intervals and statistical significance still factors into our grade assessments, and I will talk a little bit about how that is. All I would advocate for is that it's not the only factor that matters. And so grade in general as a concept, again, well accepted in the literature. As Kameshwar said, grade's not going away. It's used widespread by a number of over 200 international societies and used to develop recommendations, but also to decide on the certainty of an evidence base. And maybe to drive home this idea of grade and how we apply it, we'll look at an example. And let's say I'm a researcher in sepsis. I'm sure many of you treat patients with sepsis. Let's say a new drug has come along, and this new drug decreases mortality in patients with sepsis. And so we did a systematic review in this imaginary world, evaluating how the impact of this new drug is on survival. And when we did the systematic review, the pooled point estimate was 0.76, suggesting a 24% reduction in death with this drug, and 95% confidence intervals from 0.65 to 0.89, a statistically significant reduction in death. This systematic review in this imaginary world was based on 11 randomized control trials, 3,000 patients with sepsis. These studies were well conducted, a high number of deaths. And when we looked at those 11 randomized control trials, all of them showed a consistent benefit in terms of a reduction in mortality. All 11 studies showed benefit, and when we pulled them together, it was clear. And so, when we look at certainty of an evidence base, it's not dichotomous. It's not we believe it or we don't believe it. Rather, it's probably on a spectrum of high certainty to low certainty. And I wonder where folks on the call might be in terms of trust these results versus don't trust these results very much. And it's a bit hard on a webinar. Normally, if we were in a live room, I'd get sense from hands in the room how much people trust this. But I think looking at it, I hope you'd agree, a large number of randomized controlled trials, well-done studies, a consistent effect. No pooled body of data is perfect, but this is probably in the higher certainty. There's a lot of things that make us believe this evidence base perhaps more than other evidence bases. Keep this example in mind, and what I really want you to focus on is this pooled point estimate. Remember, 0.76 and 95% confidence intervals from 0.65 to 0.89. Because I'm going to move to a second example. The same drug in this imaginary world, looking at the effect on sepsis. And look here, the exact same pooled point estimate when we did the systematic review. 0.76, 95% confidence intervals from 0.65 to 0.89. However, in this example, it wasn't 11 RCTs that we found in the review, but only 3 RCTs. 500 patients with sepsis. Although those 3 RCTs were well conducted, again, imagine this is an imaginary world where we can control the evidence base that's there. Well conducted, fewer events. And here, in this example, 2 of the studies showed benefit of this new drug, but 1 of the studies showed harm. So an inconsistent effect. And so now, if we were to go back to our same spectrum of how much we trust this evidence base, I wonder where we would be on this spectrum. In the past, we had 11 RCTs. Now we only have 3. In the past, we had a large number of events. Now we have fewer. In the past, we saw a consistent effect, and now we see an inconsistent effect amongst the studies. And again, I can't poll the audience here, but I hope if you were able to provide your input, I'd hope your certainty assessment would be lower than it was before. Maybe not very low, but maybe somewhere around the middle in terms of how much we trust this body of evidence. Third example, perhaps you see where I'm going here. Same pooled point estimate, same 95% confidence intervals. Again, here, 3 randomized control trials, but now these 3 randomized control trials were not done very well. Major issues with risk of bias, blinding, concealment allocation, loss to follow-up. Very few events, inconsistent effects. Again, 2 studies showed benefit, 1 study showed harm. And not only that, but you found 2 more protocols, but were unable to get the data from those 2 missing protocols. And so I hope, again, if I were to poll you where we were at, is that we're down now maybe in the very low certainty, or we trust this evidence base less. And I hope this example drove home the idea that just based on the pooled point estimate and 95% confidence interval, the same element of precision, the same, if we were to use the traditional approach, statistical significance, can have varying degrees of trustworthiness depending on other factors as well. Factors like risk of bias, factors like consistency, factors like the number of events. And that's essentially the majority of the factors that grade uses when we decide how much we trust the body of evidence informing a question. We look at the risk of bias of the included studies. We look at the consistency across the included studies. We look at indirectness, one that we didn't discuss very much, but how closely the evidence base matches our PICO question of interest. We look at the number of events and the width of the 95% confidence intervals, and we look at whether there's any evidence of publication bias. And based on these factors, these domains, we decide how much we trust the body of evidence informing a PICO question. In general, pooled data from randomized controlled trials starts as high certainty. Pooled data from observational studies starts as low certainty. And then there's opportunities at a randomized control trial level to rate down the certainty in the data if there's issues in one of these domains. And when it comes to observational studies, there's opportunities to either both rate up or rate down the evidence base, depending on the factors that we discussed before. I didn't mention the rating up factors, but there are a few factors that one might consider rating up the certainty in observational studies if they are met. A couple of important things, 2 important things. This is an example looking at hip protectors in older adults in long-term care centers. Grade is not evaluated on a study level. Grade is evaluated on a pooled body of evidence informing a PICO question, and it's evaluated per outcome. So you might have different levels of certainty for one outcome as compared to another. Here, look, the example with hip protectors, there's a few outcomes: hip fractures, pelvic fractures, quality of life, and falls, and a different grade certainty of evidence for each of those outcomes. We assess the total body of evidence, not an individual study, and we assess at an outcome level. I mentioned already the domains that we assess. They're listed here on the left. This is a grade worksheet. And if there's issues with these domains, we would again lower the certainty of the evidence by either 1 level or 2 levels. And there's different guidance in each of the domains on whether we decide we might lower 1 level or whether we might decide we lower 2 levels. Remember, again, RCTs start as high, data from RCT start as high. And if there was issues with, let's say, risk of bias, and you lowered 1 level, you'd be at moderate. Inconsistency, you lowered by 1 level, you'd be at low, etc. And you work through domain by domain. If you're interested, I told you again, we can't address all aspects of grade in a quick 1-hour webinar, but we're often do grade workshops. We did the one in Ranchi last year, and we're hoping to do more, including at the European or at the Indian Critical Care Society meeting coming up. There's also great reading in the Journal of Clinical Epidemiology. There's a series of publications addressing each of these grade domains and when one might lower either 1 level or 2 levels. And they're written really nicely. So I highly suggest that if you're looking, I still go back to these publications often. I've read most of them 10 times, 15 times, 20 times, and they're extremely helpful resources. So highly suggested. But when it comes to the domains, again, acknowledging that I only have about 5 or 10 more minutes, I thought I'd talk about 2 of the domains, which I think are perhaps most important. And those 2 domains that I wanted to discuss in a little bit more detail were inconsistency and imprecision. Let's start with inconsistency. We alluded to this a little bit already with our example around the new drug for sepsis. In an example where the studies that inform the pooled point estimate suggest a consistent effect, we're more likely to believe the pooled point estimate than if they are inconsistent. Here's a great example of a consistent effect. Look, 4 randomized control trials inform this pooled point estimate. All 4 of them show benefit of this intervention. You can see a couple of them cross the line of no effect, but the point estimates all line up really nicely. And so we're going to trust this pooled point estimate much more likely in this setting because these all line up nicely. As opposed to this example, again, look, the exact same pooled point estimate, but you end up with the same pooled point estimate in this example because you have 2 studies that show dramatic benefit and then 2 studies that show harm. This is an example of a consistent effect. This is an example of an inconsistent effect. And in the setting of an inconsistent effect, we're less likely to believe the pooled point estimate, given the fact that some of the studies showed benefit and some of them showed harm. In the grade world, we call this inconsistency. This is the same concept as statistical heterogeneity. Those are synonymous, very, very equivalent terms. And so how do we, as part of grade, identify statistical heterogeneity or inconsistency? There are 4 ways, according to grade, that we assess for statistical heterogeneity. This is the whole idea. Detractors of meta-analysis talk about apples and oranges. And if studies are too different, provide too different in terms of treatment effects, should we really be pooling them together? And the 4 ways that we assess it, the first 2 involve visual inspection of the forest plots, just looking at them. And we did this already. Here, the point estimates and the 95% confidence intervals all line up really nicely, just looking at the forest plot. In this example, they don't line up nicely. The point estimates are on either side, the 95% confidence intervals are on either side. And so the first 2 ways that we assess for inconsistency are just by visual inspection. That's why I put the eyeballs on there. The other thing that we use is the chi-squared test. If you look at the bottom of every forest plot, the chi-squared test shows up. And if there's a p-value less than 0.10, that suggests important inconsistency or statistical heterogeneity. And the 4th way is using the I-squared statistic, again, a measure of variability or statistical heterogeneity. And so our assessment of inconsistency incorporates all 4 of these. When we look, it's a gestalt based on a summative look, including all 4 of these concepts. It's important to also mention is that we would only rate down for inconsistency if you can't explain the inconsistency or the statistical heterogeneity. Here's a good example. Again, looking back on the high flow nasal cannula example, where we saw statistical heterogeneity, but we were able to explain the statistical heterogeneity using subgroup analysis, looking at different comparators. When you looked at the studies that compared high flow versus standard oxygen, as compared to the studies that compared high flow versus non-invasive ventilation, that statistical heterogeneity went away. High flow nasal cannula worked well compared to standard oxygen therapy, and it did not work compared to NIV. So if you can explain the inconsistency or statistical heterogeneity using subgroup analysis, one might not necessarily have to lower the grade rating for inconsistency. I told you in this rapid fire look at grading the body of the evidence, we can't talk about all the domains, but if you'll join us for a workshop in the future, we can go into more details on these domains. We talked about inconsistency. The other one I wanted to briefly mention was imprecision. We could have an entire 2-hour discussion on imprecision. This is arguably the most important domain when it comes to grade, and there's a lot of nuance. There's a lot of challenges in applying imprecision, and so I can't pretend to be able to address it fully within a couple of minutes, but I will tell you that there's 2 approaches to assessing for imprecision. One, we look at the confidence interval. And what we do is we look at the point estimate and the either end of the confidence interval. And we ask ourselves, would we make the same decision at either end of the point at the 95% confidence interval as we would at the pooled point estimate? And if we would make the same decision around therapy, we do not lower for imprecision. If we would make different decisions, then we would lower for imprecision. The other caveat in there is that we would want sufficient sample size. And if the number of events are very low, even if we have tight confidence intervals, we might also still lower for imprecision. And here's a rough example, is that when we set our threshold for decision-making in imprecision, the threshold might be the null, the line of no effect, but it's important to be explicit because often we set a threshold that is not necessarily the null. And in this example, this was the hip protector example, we wanted to see if to justify rolling out hip protectors across all long-term care patients, we had made the decision ahead of time that we wanted to see a reduction in 10 hip fractures per 1,000. And if we didn't see that, then it wasn't worth using the hip protectors. So we ahead of time set our threshold for decision making. And then depending on whether the 95% confidence intervals cross that threshold, we would decide on whether we would rate down for imprecision. In this top example, if this was our pooled point estimate with 95% confidence intervals, you can see that the entire confidence interval, both ends of the 95% confidence intervals, fall on the side of an important reduction in hip fractures. And therefore, we would not lower this one for imprecision. In this example, this dark blue one, although the point estimate, the middle of the diamond, falls on the side of an important reduction, when we look at either end, at the bottom end of the 95% confidence interval, it crosses this preset threshold of what's an important benefit. And so in this example, we would rate down for imprecision, given that the lower end of the confidence interval crosses no effect. In this example, the yellow diamond, the entire 95% confidence interval is within the area of an unimportant benefit, less than 10 in terms of reduction in per 1,000 hip fractures. We would not rate down for imprecision, and we would conclude that there was no benefit to hip fractures. This last example, this turquoise one at the bottom, extremely wide confidence intervals that go from an important benefit to important harm. And in this example, we might rate down 2 levels for imprecision. Again, you're not going to be experts on rating imprecision in a short grade lecture, but it's important to at least hopefully understand the concepts of how we decide when to rate down for imprecision. The last thing I alluded to beyond confidence intervals is sample size. And in general, even with tight confidence intervals, if we have less than 300 of events for a dichotomous outcome, we would still lower. And if we have less than 800 participants for a continuous outcome, we would still lower for imprecision. The idea being is that the sample size is too small, the power too small, is that we still worry about ongoing imprecision. I've quickly oriented you, introduced you to the concepts of inconsistency and imprecision. If we were applying this grade to a full evidence base, we would also look at risk of bias, indirectness, publication bias, etc., and ultimately end up in an overall assessment of the certainty for an outcome as high, moderate, low, or very low. Depending on the effect and the certainty of the evidence, grade also provides guidance on how to summarize, how to narratively describe the results of your systematic review. This is a great publication in the Journal of Clinical Epidemiology by Nancy Santesso, and it provides guidance on using different wording, terminology around high certainty, moderate certainty, low, or very low. Here you can see when it's based on high certainty, we say things like results in a large reduction. If moderate certainty, we start introducing qualifiers like likely results in a reduction or probably results in a reduction, recognizing the ongoing uncertainty. Low, now using words like may result in an important reduction. And if we end up as very low certainty evidence, the conclusion is an uncertain effect. A bit of a whirlwind tour of applying grade, the fundamentals of applying grade. Hopefully that gives you a little bit of an orientation around why we use grade, how we apply grade, and how we use grade to summarize the results of our systematic review. Again, I'll put in a plug for expanding your knowledge around grade, whether it's through reading or through one of our McMaster workshops, and hope to be able to provide further guidance education sometime soon in the future. And on that note, I will stop sharing. And Jay Kameshwar, I'm not sure if we want to jump right into Dr. Depine.
Thank you. Thank you, Bram. And now I request Dr. Bhattacharya to introduce our second speaker, Dr. Chaudhary, for his talk. Dr. Bhattacharya.
Yes, sir.
Yes, please.
Our next speaker is Dr. Dipayan Chaudhary. He is from Department of Health and Research Methods, Evidence and Impact, McMaster, University, Hamilton. And his expertise in grade evidence, and he has got many publications on reputed journal, and he is also expertise in systematic reviews and meta-analysis. May I request Dr. Dipayan, please, to start.
Thanks for that introduction. I'm just going to start sharing my screen right now. Okay. All right. Okay. So thanks again to the Indian Society of Anaesthesiologists for inviting myself and Bram to this talk. So I'll be sort of kind of launching off of Bram's talk and really elaborating on how the grade methodology and the grade system is used by guideline panels to make guideline recommendations. And this is known as the evidence of decision framework. So to design sort of standardized, clear, transparent guidelines is a very involved process. It requires multiple steps and considerations. A good evidence profile has to be generated. And on top of that, other considerations such as the quality of the overall evidence, the benefits and the harms, the values and preferences of the intervention that's being looked at, its feasibility, its resource use, all need to be considered. Now, the guideline panel needs to look at all these things along with the evidence profile and sort of collate it and consider it all together to come up with a fairly simple recommendation that can be easily understood by readers. This process can be pretty challenging and chaotic. And so the evidence of decision framework really exists to sort of simplify this process and standardize it to make it a lot easier to sort of design these guidelines. So for the rest of this talk, I'll be going over a summary of the evidence of decision framework. Just like Bram's talk, the framework is a pretty involved process and has a lot of moving pieces. So I won't be able to go into all of the pieces in a lot of detail, but what I hope to do is provide a general overview for everyone. And then, if there are further questions, we can address it in the question period after, or at one of the great workshops that Bram mentioned. So the first step for any evidence to decision framework is to generate an evidence profile. Now, I'm sure this table looks pretty familiar to you all from the last talk. And it's essentially a summary of the evidence that's available on the clinical question or the clinical questions that is being looked at. So this evidence profile, for example, looks at the clinical question that addresses the deployment of an early warning system versus no criteria to be used in adult non-ICU hospitalized patients. And just like the great evidence profile, it's split across the different outcomes that are relevant to this clinical question. So 2 of the outcomes reported here: hospital mortality as well as cardiac arrest. Now, there are 3 main components to the evidence profile. One is the impact or the effect. So for a lot of evidence profiles, when you have a lot of studies that have been collated or pooled together, the impact or the effect is essentially the pooled relative risk, odds ratio, or mean difference. However, for some clinical questions, the studies can be pulled together. Oftentimes it's because there are varying designs, or their patient populations are all slightly different, or their interventions are slightly different. In those cases, the impact or the effect would just be a sort of qualitative summary of the evidence that's available. And you can still make generalized statements such as the majority of the studies demonstrate a reduction in hospital mortality, or the majority of studies don't show any difference in mortality. The second component of the evidence profile is the certainty, which Bram sort of went into detail in the previous talk, so I won't discuss too much. And the final component is the importance of the outcome. So this is so for basically almost all guideline panels and for almost all clinical questions, one of the first steps is to decide what the patient important outcomes would be. Then these outcomes are put together and sent to each of the guideline panel members to rate from a degree of least important to most important. Usually this is done from a scale of 1 to 10. Once each of the guideline panel member rates each of the outcomes from most to least important, these are all brought back together and averaged out. And typically what's done is, let's say the most important outcomes, the ones that are rated, let's say 7, 8, 9, or 10, are rated as of critical importance. Outcomes that are rated from 4 to 7 are rated as of just important. And then outcomes that are rated 1, 2, or 3 are rated as non-important. This is useful later on when we look at the judgments that are needed to be made and the overall recommendation, which I'll go into in a little bit. But it's not just the evidence profile that the guideline panel needs to consider. They also need to look at patient values and preferences, healthcare provider values and preferences. They need to look at the acceptability of the intervention being considered, health equity issues, resource use, and a bunch of these other criteria as well. Now, traditionally, before a framework was built on this topic, trying to consider all these additional criteria as well as all these clinical questions, outcomes, often created a very chaotic environment where a wholesome discussion was often not had, important points were missed, the loudest people often got heard most often, and overall, it was an environment of chaos. So to sort of circumvent this environment, frameworks were needed. A framework was needed to present the evidence to the guidelines panel, and that's the evidence profile I talked about. A framework is needed to organize the decision-making process, and that's the evidence of decision framework. And a framework is also needed to avoid conflicts of interest in decisions and ensure transparency. And that's something that's not really the topic of this talk. That's not really a sort of a part of this talk, but is definitely something that's important to consider. So this is what an evidence to decision framework looks like. It's essentially a table with each of the with all important sort of judgment questions included, as well as the evidence. So I know this table looks quite complicated, so I'll break down each of its individual components in the next few slides. So the evidence to decision framework has been now used pretty frequently over the last decade or so. It's been used in over 15 international guideline panels, including pretty large international ones, and it's been tested in over 200 recommendations. And over time, it's slowly become established as one of the standards for guideline panels and for making recommendations. So what needs to be included in the framework to help go from evidence to decision? Well, how large are the benefits of the treatment and how large are the harms to the treatment? And what's the overall balance of effects for the treatment? Is the treatment or the intervention going to cost money, or is it save money? Is it going to save money? Is it acceptable? Is it going to improve health equity across populations, especially across marginalized populations? And is it even feasible? So the responsibility of the guideline group is to look at the overall evidence that's available on the topic, look at the questions I just mentioned in the previous slide, look at the questions for the previous slide, and look at the overall evidence, and then make a recommendation based on the answer. Sorry, I think someone's mic is going off. If they don't mind muting it.
Dr. Neha Kumari, please mute your mic.
Yeah.
Okay. So for each of the judgments we talked about, they're sort of outlined in the table as you can see here, and there are 4 important components or columns to consider for each of the judgments. The first is the criteria. So that's essentially the judgment question that the guideline panel is asking. So for the judgment about resource use, the criteria, the question that's being asked is, does the cost effectiveness of the option favor the option or the comparison? The panel then looks at the overall research evidence that's available to try and answer this question. So for a question about hip protectors, the panel looks at whether there have been any cost effectiveness studies, any costing studies that look at the resources involved in applying this intervention. Then the panel also discusses any additional considerations that may be relevant or important to answer this question. And then combining the research evidence along with all additional considerations, they make an overall judgment. Now, this is a consensus judgment that the panel makes together. And then once they make this consensus judgment, they do the same thing for all the other questions that I mentioned earlier. Then, by combining all the judgments, it helps lead them to a recommendation, again, based on consensus. Now, a recommendation has 2 important components. The first is the direction of the recommendation. So whether the panel makes a recommendation for or against their intervention. The second component is the strength of the recommendation. So whether a panel makes a strong recommendation for a certain intervention, or whether they make a weak or a conditional recommendation for an intervention. Now, what does this mean? A strong recommendation means that the balance is strongly in favor of an intervention. So a strong recommendation for means the balance is strongly in favor for a recommendation. This means that in most or almost all clinical cases, a reasonable clinician would choose an intervention. A weak recommendation or a conditional recommendation for an intervention means that while in the majority or more than 50% of cases, a reasonable clinician would choose the intervention, there's a significant proportion of cases where a clinician may not choose an intervention because of other patient important factors or resource considerations or things like that. So sort of to reiterate, a strong recommendation is where a panel is confident that the benefit is going to outweigh harms in almost all individuals. There is little to no variation in values and preferences. The cost is not prohibitive, and the intervention is acceptable to all stakeholders. In these cases, the wording that is used is the word recommend. So when a strong recommendation is made, the panel would say something like, we recommend for this intervention. Or if they're making a strong recommendation against something, they would say, we recommend against this intervention. A conditional recommendation is, like I said, a one where, while the majority of the time the panel would recommend this intervention, it's not in every case. The panel is not confident that the benefit outweighs harms in almost all individuals, or there's a lot of variation in values and preferences, costs, or acceptability to stakeholders. In this case, the wording used is suggest. So the panel would say, we suggest for this intervention, or we suggest against this intervention. Now, there is also an option of no recommendation. This is infrequently used, and usually if there's little credible evidence to guide the decision. However, GRADE usually recommends that a panel try and avoid the no recommendation option. This is because guidelines are generally sort of designed to help clinicians make decisions. And a no recommendation option really doesn't help a clinician pick one option or the other or guide them in any way. So if at all possible, GRADE strongly pushes or encourages guideline panels to either make a recommendation for or a recommendation against whatever intervention is being looked at. So what does the end product look like? So for example, when a strong recommendation is being made for daily supplementation of vitamin D3 in long-term care residents, it would look like this. For long-term care residents at high risk of fractures, we recommend daily supplementation of 800 to 2,000 units of vitamin D3. And then in brackets, the strength of the recommendation, so strong recommendation is stated, as well as the overall certainty of the evidence. For a conditional recommendation, the wording would say, we suggest, in this case, oral H1 antihistamines rather than oral leukotriene receptor antagonists in patients with seasonal allergic rhinitis. And again, in brackets, the strength of the recommendation is put down, as well as the certainty of the evidence. As you can see here, and as Bram mentioned before, you can have the same certainty of evidence, but based on the other value judgments that are involved in recommending an intervention, the strength of the recommendation can change. So when do we use the evidence of decision framework during a guideline panel? Well, we would argue that it should be used in every step throughout a guideline committee panel meeting. So it should be used before the meeting. That's just to prepare the evidence for the meeting itself. It should be used during the meeting to present the evidence, to organize a discussion, as well as to keep track of discussions and judgments. And finally, it should be also used after the meeting to have a transparent record of the meeting, to communicate to users what the thinking and the rationale was behind the recommendations that were made, and also to help write up the manuscript for the final summary or guideline. So while I can't go into detail about all the judgments that need to be considered when looking at evidence to decision framework, I thought I'd spend my last few minutes briefly outlining what the judgments involve and what is an important part of it. So the first judgment that's often looked at when looking at the evidence decision framework is the values and preference judgment. And that's essentially, is there important uncertainty about or variability in how much people value the main outcomes? So in this judgment, this is where the importance of the outcomes come into play. If a lot of the outcomes you look at are rated as critical or very important, clearly this is a very important or valuable outcome or question being looked at. In most cases, if the guideline is coming together to look at a certain outcome or clinical question, clearly this is an important outcome. And in most cases, thus, there is important uncertainty about the question, or there's possibly important uncertainty about the question. Next, the guideline panel looks at the anticipated positive and negative effects of the intervention, as well as the overall certainty of the evidence. And again, the overall evidence profile is considered, as well as any additional considerations that the panel might have, and the size of both the anticipated effects and the undesirable effects are decided upon by consensus. The overall certainty of the evidence is not as much of a consensus, but it's looked at by looking at the evidence profile more than anything else. Next, we have to consider the resources. So resources is not just about the money or the cost of an intervention, but it's also about the staffing, the training, the equipment that's required. For ICU-specific guidelines, this might mean needing an ICU bed. For specialty surgical services, it might mean requiring specialty ORs, special surgeons trained in special procedures and things like that. So these are all things that need to be considered when looking at the resource cost and the cost effectiveness of intervention. The acceptability is essentially, is the intervention acceptable to key stakeholders? So this is essentially, would this be an acceptable intervention to patients? Would it be an acceptable intervention to healthcare providers? Certain interventions that may save lives may not be as acceptable to patients because of other costs. So for example, something like an amputation, which may show benefits may show a slight reduction in mortality, may still not be acceptable to certain patients based on their values and preferences. Equity is also a very important consideration. So certain interventions may reduce overall health equity. So for example, if a committee is making a recommendation for ECMO in patients with severe ARDS, oftentimes patients in lower resource settings or patients from low socioeconomic status may not be able to afford these interventions. And in these cases, it's important to consider whether certain interventions are broadening or worsening health equity. And finally, feasibility. So while an intervention, again, going back to the example of ECMO, while an intervention may very well reduce mortality and be cost effective, if the intervention is being considered in a very low resource setting or in a small hospital, where there aren't a lot of extra resources or surgical support, it just wouldn't be feasible. And an intervention can be amazing or great, but if it's not feasible, it's really not useful. So that sort of is a brief outline of the evidence of decision framework. I would encourage you to look at some of there's software and websites available that help guide you through this framework. They have interactive tables as well as sort of methodological documents and how-to documents to help sort of answer these, to help fill out these frameworks. One of the ones that I would recommend is the Great Pro website, as well as the Magic app. I would encourage you to check both of these out, and both of them are quite good, and they can really help sort of design this ETD framework. And that's it. Thank you.
I got question through YouTube link because I have here capacity to only add 100 people. So I sent link on YouTube. I got question that whether by looking confidence interval, how we will make possible that this confidence interval is wide or narrow.
It's a great question, Jay. Thanks. I'm happy to address because it was a part of the great talk. As I say, rating imprecision, there's a lot of, you could dive deeper into this concept and how we rate, but the general approach, Dr. Jay, the general approach is to look at the pooled point estimate and decide whether that pooled point estimate is suggesting either benefit, harm, or no effect. And so depending on what your threshold for an important effect is, you look at the pooled point estimate and you decide. Then you look at either end of the 95% confidence interval. Let's say we look at the pooled point estimate as we did in the sepsis example. And when we look at the pooled point estimate, it suggests a benefit with the therapy. Great. We look at the lower end of the 95% confidence interval. Does that also suggest a benefit with the therapy? Then we look at the upper end of the 95% confidence interval. Does that also suggest an important benefit of the therapy, depending on what our threshold is? If it does, then we do not need to lower for imprecision. If at the upper end of the confidence interval, it suggests no difference or harm, despite the pooled point estimate suggests benefit, then we would lower for imprecision. That's a rough guideline. But again, there are more intricacies to this, including one of the big ones is we've sort of contextualized this around the relative effect of the intervention. But if one is rating grade, actually, we should be looking at the absolute effect of the intervention as opposed to relative. So that's one of those intricacies that I discussed. But again, hard to go into an extreme level of detail in the time frame that we had.
One more question is that, as you said, only in randomized control trial, we have to rate down. Why not in observational study?
Great question as well. Maybe I misspoke. RCTs start as high, observational trials, pooled data. Remember, we don't apply grade at a trial level, but pooled data from RCT starts as high. Pooled data from observational trials starts as low. Both we can rate down for. So if there's issues, concerns around any of the domains we discussed, we might rate down. When it comes to rating up, and I did not talk about this very much, there are opportunities to rate up data from observational studies. The big reasons being a large effect, a very large treatment effect. If there's evidence of a dose response from the intervention, so at a larger dose, bigger effect, smaller dose, smaller effect, that suggests a more true effect. And if they've adjusted for a lot of plausible confounders. And so there are opportunities to upgrade observational studies that we don't do with RCTs. So either RCTs or observational studies can be downgraded. Generally, only pooled data from observational studies are upgraded.
And one more question to Dr. Dipian, that as you said that if there will be moderate certainty of evidence, but still it can be a strong recommendation. How?
Yeah, so I mean, look, we have to consider the overall picture when we're sort of looking at the evidence. So even if this is rare, but even if the certainty of the evidence is low, but there is a very, very large effect size or a very large benefit, anticipated benefit seen with an intervention, and very, very few anticipated harms. And the intervention is very cheap, and it uses very few resources, and it's very feasible. Then you could still make a strong recommendation for something, even though the quality of the evidence may not be as strong.
Okay. One last question I would like to ask. So as you said that if there will be a small sample size, so we can lower down the imprecision. But how we will decide this a small sample size is lower or not?
A great question, Jay. There's a few ways that we decide. The easiest way is that rough guideline that I mentioned. If it's a dichotomous outcome, you want to see at least 300 events. So for example, if the outcome is mortality, you'd want to see at least it doesn't matter the sample size of the included RCTs, but you'd want to see at least 300 events, 300 deaths between the pooled intervention and pooled comparator. That's the easiest way. For a continuous outcome, at least 800 patients between the intervention and the comparator arm. If you look at the imprecision paper, there's a graph that plots out the effect size and the baseline risk. It's like a rough sample size calculation for your meta-analysis. And it's, again, you can plot in the graph to see whether you've hit your optimal information size, we call it. The third way, and the way that's gaining in popularity in the last little while, would be doing something like a trial sequential analysis, which again is like a rough way of doing a sample size calculation for your meta-analysis to see if you've achieved adequate sample size. Those are, I guess, in increasing complexity, the ways that you might assess for adequate sample size. The bottom line is just being transparent and upfront in however you assessed it and making sure that you're not having high certainty evidence based on a small number of events, even with tight confidence intervals.
Okay.
Bram,
Right, so there are no more questions.
No, three questions they asked through YouTube link they sent me.
okay, Bram, I'm asking you one question. There is, you said it, overall quality of evidence, isn't it? So how you take it as an overall quality of evidence, how you decide that? Suppose you have the way you described in your first 3 slides, the confidence interval changes and the quality of evidence also decreases or increases according to that. So how you decide this overall quality of evidence when you have 5, 6 outcomes in your hand?
Great question, Dr. Pradeep. And there is some general guidance from GRADE for this. And, to be explicit about Dr. Pradeep's question, let's say mortality is high certainty, need for intubation is moderate certainty, hypoxemia is low certainty. Well, now you have 4 or 5 outcomes of varying certainty, because you remember that you apply GRADE at an outcome level. If you wanted to come up with the overall certainty assessing high flow nasal cannula in patients with acute hypoxemic respiratory failure, how do you incorporate the different outcomes into a single certainty? And there are some guidelines from GRADE on how to do this. Generally, we take the lowest certainty amongst the critical outcomes. So, you decide ahead of time, as Dipayan mentioned, which outcomes are your critical outcomes for patient importance. Maybe in this example, we say mortality is critically important, quality of life is critically important, intubation is critically important, but, PF ratio, probably not critically important for patients. If you were to ask a patient whether they cared what their PF ratio is, they probably wouldn't care. And so then we would take the lowest certainty amongst mortality, need for intubation, and quality of life. The only caveat to that is, according to GRADE, is that if there's a consistent benefit seen amongst, let's say those are our 3 outcomes of interest: mortality, need for intubation, quality of life. If the benefit for high flow nasal cannula is consistent across all 3 of those, mortality shows benefit with high flow, quality of life shows benefit with high flow, need for intubation shows benefit with high flow. If it's consistent, then we can take the highest certainty amongst those. So let's say mortality was high, intubation was moderate, quality of life was moderate, and they all show consistent effect, we could use the high certainty from mortality across the PICO question. But if one of those, let's say high flow was beneficial for mortality, high flow was beneficial for intubation, but high flow was harmful for quality of life, it was not consistent, then we'd have to use the lowest certainty, especially for whatever was quality of life. So the general principle, again, to summarize, we use the lowest certainty across the critical outcomes. However, if you see a consistent effect, you can use the highest certainty across those outcomes where there's a consistent effect.
And I add one more thing in that, because you are also author in that paper. So we should always take that which is clinically relevant, and we should make that research question on the or our primary outcome. So it will be very easy to recommend if we will put many outcomes together, primary outcomes. So always better to make one outcome, which is clinically important.
And expanding on that, absolutely agree, Dr. J. And expanding on that, there's debate on what's clinically important. I'd say, the most important would be what do we think is important for patients, right? And a good example would be that, hypoxia, as clinicians, we think, oh, PF ratio is really important. A high PF ratio is good, a low PF ratio is not good. But if we were to ask a patient wouldn't care what PF ratio is. They would care about, do I need to be intubated? Am I going to die? What's my quality of life? So when we're thinking about outcomes, as you say, relying on the ones that are most clinically important, I would say, even be expanding on that, what's most important to patients should be what we rely on highest.
Okay.
Thank you, Bram. Kameshwar, sir.
I think both speakers have done a marvelous job. My own focus was how they deal with grade in such a short time. And if I was asked to speak, I will be very perturbed. How can I cover so much ground within 50 minutes? And never given a talk on 25 minutes on grade quality of evidence. So Bram has been brave as well as, I think, very, very effective in conveying the main messages. and so has been Dr. Chaudhary, because again, I had to do it for Indian Academy of Neurology. So I took 1 hour for certainty of evidence and another webinar, 1 hour for evidence to recommendations. You did an excellent job in 25 plus 25 minutes. You covered, I think, extensive ground, that also very effectively, very clearly, very lucidly. So thank you very much for doing this favor to us. I will hand over to Dr. Bhattacharya and to the Dr. Bhimeshwar and Dr. Devatia to close the session with some remarks. Thank you.
Thank you, sir. So it has been a great session, and we have talked about grade. We have talked about correlation of evidence-based medicine with grade, and how to provide certainty of evidence, then how to increase confidence, then making guideline, meta-analysis, and how it works in healthcare practices and how to recommend. So I think almost everything in such a short period of time, it's a great job done by speakers. I think it is really highly appreciable. And I presume that all those listeners who are attending this lecture series must have got a highly benefited from this. And obviously, to understand more and more, you have to attend workshops, and then only we can understand in much more detail about grade. So thank you from my side. And I hand over the mic to Jai Prakash.
So I would like to give word of thanks to our respected chief guests, both Dr. Bhimeshwar sir and Dr. J.V. Diwatia sir. And I would like to thank to bottom of my heart that my teacher, my mentor, Dr. Kameswar Prasad sir and Dr. Pradeep Kumar Bhattacharya sir. And thank you both speakers, Dr. Bram and Dipayan, to be part of this nice presentation. I would like to thank to all my listeners. Thank you.
Jai Prakash, please, certificate of participation.
Yeah. I will send on their personal WhatsApp number. Why? Because Bram and Dipayan is rarely using WhatsApp. And so I will send them on mail.
Okay. Thanks to everyone.
Thank you, everyone. Wonderful session. Good night.
Good night.
Thank you, sir. Bhimeshwar sir, Devatia sir, thank you.